All right, let's see, we're at 2:02. Um, let's go ahead and get started. Got more than 20 people on the line, which is awesome. Great to see all of you. So again, I'm Keith Coker. I am an emergency physician at the University of Michigan. I'm going to be playing the role of host, along with Katie McComber, who will be the main presenter today. We'll introduce her in a bit. But just to set the stage a little bit, first remember that I just mentioned this already. There's a Qualtrics related survey with a QR code that you can see on the screen now. It'd be great if you could complete that survey. It's pretty short. Some point during the talk today, we'll show it again at the end, just to give us an idea of some of the perceptions that exist out there in the audience. Additionally, I just want to provide a little bit of context. So I am also one of the medical directors for the Michigan Emergency Department Improvement Collaborative, what we call MEDIC. And we're partnering with the state Michigan Department of Health and Human Services on this work. This is actually really one talk in a learning series that we are supporting, and you'll hear more about future ones. And certainly, if you're interested in being part of that, we can get you on the listserv. And really the goal here is to advocate for implementation of screening programs in emergency departments. And it's really a setting that is not been leveraged well enough to identify patients who might have HIV. And we're using our network of more than 50 hospitals to consider doing this work. And it fits within broadly our perspective of improving the quality of care in the state. And so one of the things that we've heard about as a major barrier in our work is really this concern about linkage to care. And of course, emergency departments are strapped. There's this perception there's not enough capacity in the hospital or the health system to deal with linkage to care. So yes, we may identify a patient who's HIV positive, but then what do we do next? And it's really, caused some concern around just getting into the action of doing screening. And we really wanted to address that head on because there really is a lot of resources available in the world of public health that a lot of us in the hospital are not aware of. So with that, I'm going to hand things over to Katie McComber to talk about that. She's the Bureau Director for HIV and STIs at the state. So Katie, take it away. One point I'll say is please, we welcome questions and comments. I'll monitor the chat and facilitate any questions, but certainly there'll be other times to ask questions along the way too. All right, Katie, floor is yours.
All right, thanks, Keith. Appreciate it. Please bear with me while I share my slides real quick. Right. All right. Well, again, thanks everyone. Good afternoon on behalf of MEDIC and the Michigan Department of Health and Human Services. Really happy to have you here today. It's really our honor to help support learning around HIV and emergency department testing initiatives by providing some education about the wealth of supports to providers and patients really across the continuum of testing, linkage, and access to care in Michigan. Like he said, I serve as the HIV STI director here, where I oversee staff who support implementation of federal funds and federal programs to prevent, treat, and care for those affected by HIV and STIs. I want to be clear today that while you'll hear a little bit about STIs and during this learning series, occasionally viral hepatitis, the information that I'll be presenting today is mostly limited to HIV as the resources available to folks differ a little bit between those different infections. So today this is a sort of a brief layout of the agenda of a variety of linkage to care and support programs that we're going to talk about. On this slide, I want to talk about a few different process flows when a person tests positive, either in a clinical or non-clinical setting. I'm not sure everyone is aware of this, but the department supports a lot of testing, rapid-based testing, CLIA waived rapid testing in non-clinical settings. But when we're talking about either of those types of setting, every day in Michigan, providers deliver results and report communicable diseases to MDHHS and help people make follow-up appointments for specialty care. If you work in an emergency department, likely some of the reporting from your facility happens via your lab, via electronic lab report, and the case reporting likely happens through your infection control department. In Michigan, providers also have the ability to help clients inform their partners and or ask the health department to support the client in doing that. We'll talk a little bit more about that later. Also in Michigan, testing providers can even provide Rapid Start, which is kind of same day treatment for HIV. That's a new evidence-based intervention. We'll talk about that a little bit later too. However, it's important to know that even in an ideal world, the left-hand side, where a provider informs the client, the provider links the person to care, the person gets to care, and that all works smoothly. That's great. It's good to know that on the right-hand side, there's a whole different complementary process flow where that information is also shared with local health departments and MDHHS in Michigan, and the same processes also go through. Of course, we know on both sides that there are people that don't make it all the way to the end of this continuum because they refuse assistance. We can't get a hold of them. They've moved or they've lost access to a phone or their housing. And so I'm not saying that every person, flows through both sides of these perfectly, but I just want to let you know that both sides are available. Early on, when we talked about testing in HIV or in emergency department settings, there was questions about consent for testing. I wanted to make sure, as a foundational item, that folks here know that prior to 2018, if someone came in for an HIV test in a clinical setting, they actually had to sign sort of a formal, for those of you that have maybe worked in a clinical setting for a while, you might remember it was like the department provided this little form where people actually had to consent for testing. The Michigan Department of Health and Human Services worked with the legislature in 2018 to remove that requirement. So the law doesn't require that a patient or their authorized representative provide special or separate consent for testing. General informed consent for medical testing is sufficient. So, however, that doesn't mean you don't need to inform a person. So prior to ordering an HIV test, a healthcare provider must inform the patient or authorized representative, either verbally or in writing, offer them the opportunity to ask questions and decline. And you only have to document in the medical record if the client declines. Okay, so you might wonder how the Michigan Department of Health and Human Services and local health departments can assist providers in doing this linkage work. And that's really based on the foundations of laboratory reporting. According to Michigan law, all HIV and STI diagnostic labs must be reported to the department within 24 hours. Most hospitals and major reference labs in Michigan report electronically. Many of them, we get them within a day or so. And we get labs electronically through the laboratory and facility, or occasionally some send them faxed or in flat files for manual data entry or uploads. So while I talked earlier about the right side of the flow, I want to reiterate that while we do get information and we do assign it to staff to do the linkage and contact folks and provide resources to help them get to care, we are going to do it slower than you. So that you can see here, this is just the average number of business days. Again, our staff are working, sort of business hours on and not working weekends. So you can see it really takes about 9 days for a new HIV case to get assigned to a DIS. And we'll talk about what a DIS is in a minute. For them to go out and contact the person to provide all these supports. So just putting that out there, that while it is a complementary system, I think it is a little bit slower than possibly what can happen in an emergency department. Okay, the next slide. Just wanted to remind everyone that Michigan law also requires providers to report. There are many variables that we are required to send to CDC that we cannot get on an electronic laboratory report. Mainly, those are just the laboratory report and a couple demographics. Frequently, some of the demographics are important demographics are missing. So we still require, some of these reporting to be done via fax, and frequently infection control, at least in many facilities, is involved in this process as well. The good thing to know is that our staff do have EMR access to many of the health systems. So if we get one of these forms and it's grossly incomplete, or we don't get it at all for whatever reason, we do have the ability to go into many of the EMRs to complete the required data that's required to be submitted to CDC. Just a little bit of fun information. I don't know if this is fun information, but we just want you to know that if you're a provider, you can call MDHHS at any time. Sometimes you might test a person and maybe you aren't sure if they're a new case. Maybe they might have moved here recently and maybe they've had HIV for a long time, or you're not sure if they're in care. Any provider who's treating a client can call MDHHS. If you don't even know the next steps or need assistance, we have a phone number where folks, can take those calls and assist in answering those questions. If you're interested in other important guidance around communicable disease reporting, all of that information is at michigan.gov/CD info. It has, a lot of information about reporting beyond just HIV and STIs. And I previously mentioned on the previous slide that our staff has access to EMRs. So obviously laws and statutes are important for your legal department, I think, to answer questions when we start new projects like this. We have really tried to put all of the legal laws that affect physicians and local health departments in a compendium. It is on our website, michigan.gov /HIV STI. It's under the resources link, and then there's a section that says HIV laws. It is way more comprehensive than we have time to cover today, looking at disclosure, reporting, sharing data, requirements for testing and pregnancy, and consent and mandatory testing. So earlier I mentioned partner services. What partner services is a legislative mandated program to help reduce the transmission of HIV and STIs. Mostly we do partner services for syphilis to sex and needle sharing partners of people who test positive. It's really important to know that partner services is voluntary. You can refuse to talk to someone who calls you for partner services. You can talk to them, but refuse to name partners. So it's very voluntary on all steps. And it's authorized through the Public Health Code 333.5114. And it's operational through a hybrid network of MDHHS staff and local health departments. And the folks that do it are called disease intervention specialists. There are DIS as well for tuberculosis and for viral hepatitis programs, among others. So they conduct one-on-one counseling with people newly diagnosed with HIV and STIs. They provide education on disease transmission. They refer folks to care and services. They present options to notify partners. So the health department can notify your partners, the client can notify their partners themselves, a physician can notify the partners for them, or a combination. And once those partners are notified, we offer testing, treatment, and support services for the partners. And like I said, it's a hybrid model. So syphilis is conducted entirely by MDHHS staff. HIV in Detroit is conducted by MDHHS staff. Many large counties, so Kent, Ingham, Washtenaw, Genesee, have their own partner services staff. And then, in the more rural counties, we sort of have this hybrid group because they obviously don't have as many cases. So we have sort of a regional approach there. We can do partner services over the phone, and we can use dating sites to help notify partners who may be somewhat anonymous, or folks that they had only met over a dating site, so may not have phone numbers, addresses, full names, and things like that. We can provide transportation for treatment and reminders for appointments, and sometimes can do field delivered therapy. That's mostly a syphilis issue. And we have a whole special group dedicated to to the special needs of pregnant women who might be diagnosed with HIV or syphilis. Okay, I want to talk a little bit about linkage programs. Um, So we have some programs and projects specifically designed to support linkage and retention and care for people with HIV who are eligible in Michigan. Some of these programs require eligibility and some are for all people with HIV. We'll talk about some of the eligibility and specifics in a minute. The first program I want to talk about is the Early Intervention Services Program, or EIS. It places special emphasis on helping people who are newly diagnosed with HIV to connect to medical care and other services. They help folks find a doctor or a clinic and make an appointment, apply for health insurance, understand HIV medical treatment, find support groups, and really do a full socio-determinants of health assessment, looking at things like transportation, food, housing, things like food security, and various other needs that a person might have. So these are locations where where there are agencies who provide EIS in Michigan. So you can obviously also Marquette has that services. So there's one agency in the UP, but I cut that off for the sake of the picture. And Traverse City, the Munson and Traverse City serves a lot of the upper area, but you can see that most of the major metropolitan areas have one EIS location in them. All of these agencies' names and contact information and the specifics of them are located in our HIV Care Resource Guide, which is linked there. Okay, so we recently released a rapid start guidance, and this is just, if you hear the term or it's frequently taught, we're talking about it now when we talk about providers who might be diagnosing. This project serves to get people newly diagnosed with HIV on ARV medications sooner, in some cases the same day. This is a new evidence-based intervention to help rapidly drive down community viral load. You can read who would be a good candidate for My Start Here. Our Rapid Start protocol is also on our website. And how this project functions is by getting free sample starter packs for HIV ARVs from the major pharmaceutical companies. So if this is something that you're ever interested in, you can read more about it on our website. So you might be asking about someone who's had HIV for a long time and has been out of care, or maybe they moved to Michigan and they're not newly diagnosed, but maybe you're sort of elevating an HIV diagnosis to them in an emergency department setting. We have a program with linkage specialists who help contact people and link folks that are out of care. We use the absence of clinical laboratory data as a proxy for people not being in care, and have staff contact them to support getting back into care on meds and sometimes getting back into case management. We also do that for people with HIV leaving corrections, so people leaving the Michigan Department of Corrections, and we do it for some people who are associated with pharmacies and don't pick up their medications. This project is regionally supported with folks in Detroit, the Northern, Lower Michigan, the UP, and the rest of the state, and some of that website is located there. This is a little bit of our process. So this is just meant to educate you to that if you diagnose someone with HIV and they never get into care, or they get into care and then they fall out again, we have this really robust network to find those folks and try and contact them, send letters, all with a real lens of confidentiality and security to try and support people even that were in care and fell out of care for whatever reason. Okay, let's talk about the Ryan White program. I'm not sure how many folks have heard of this, but it's a robust program for people with HIV who live in Michigan who are under 500% of the federal poverty line and not eligible for Medicaid. This program is the payer of last resort, but let's explore some of the providers and services and what are offered to people in the program. So first I want to mention that Ryan White is divided into several parts. A is the Detroit EMA, and B is the balance of state, and some agencies also receive Part C. University of Michigan receives Part C. So it's a federally funded program that that runs through a variety of state and health system to fund the supports. We're just going to focus on A and B today, and we have Ryan White agencies embedded in health systems and based in the community around the state. This is just some of the eligibility for the Ryan White program. And so this is just a way for you to know that if you diagnose with someone with HIV, even if they don't have any insurance, they're underinsured, Ryan White can support their full medical needs. Here's the locations of the Ryan White B locations. And here's all of the locations of Part A in the Detroit area. So you can see it's a very robust network of providers, and people have a lot of choice, especially in Southeast Michigan, on where they go for these services. These are the services that case managers at Ryan White agencies can provide to people. You can see they really provide a whole person, full program support to help people stay healthy and access services in the best way for them. We're really going to focus today on the AIDS Drug Assistance Program, or ADAP, and the EIS program. So what's MIDAP? The Michigan AIDS Drug Assistance Program is a federally funded program that provides HIV-related and other medications to eligible applicants who have limited or no access to insurance coverage. Again, this is for people that have a federal poverty limit more than Medicaid, but less than 500%, and we are the payer of last resort. And we have a wide variety of choices for people who enroll in this program. We can purchase insurance for folks through the marketplace. We can provide gap coverage if folks are on Medicaid and need help with premium or copays or coinsurance. We can support COBRA if someone previously had insurance and for whatever reason don't have access to that anymore. And then we can just provide access to medication without the various types of insurance enrollments. So ADAP doesn't only not just pay for HIV medications, but we have a mostly open formulary that includes mental health medications, chronic disease management, among others. So I've given you a lot of information today, and I want to point you to our website, which has a lot of information on extra support after the call ends. First of all, we created this really great infographic called You Test, We Do the Rest. And it sort of lays out all of the things that we talked about today. It lays out what DIS can do. It lays out partner services. It lays out the various phone calls and how to find a DIS or linkage specialist in your county. So links you to who your local resources might be. This is a great resource you can get from our website to share with staff in your facility, or even just provide a quick resource of all the things I've talked about. In addition, we just have a wide variety of brochures on our website to order, which can be given to clients about the Ryan White program, about what, we have a brochure for people that have newly tested positive and a brochure on partner services. The best way to get all this information is to sign up for what we call Shores, which is our CRM or our customer relationship management system. And the instructions on how to do that are to the right. Then you'll get our newsletters. You can request data from us, request brochures, etc. Again, our website is www.michigan.gov/HIV/STI. You will find more information that we talked about today under the Ryan White AIDS program link or the resources link on the website. That is all I had today. I wanted to take time for any questions, and then I know that the folks from Medic are going to be launching a second poll in a couple seconds, but happy to take questions.
Yeah, so what you see before you now is a Zoom poll just to give us some feedback about this topic from all of you. Right now, I don't see any questions in the chat. I certainly have a couple questions, but certainly this is a moment for anybody to come off mute and ask or pop something into the chat. Katie, I'm going to kick us off with a question to you.
Great.
It's always amazing to me to hear about the incredible amount of resources,
Yeah.
available, outside my world of the emergency department and in the hospital in particular. But I definitely noticed that there is some variation across kind of local communities and counties and cities with what is available. And I'm kind of curious about like how, as you think about the statewide landscape, like does that leave any differences in how care is approached or how we should consider, our local community resources when we're thinking about linkage to care?
Yeah, absolutely. And I think at our next learning session, I believe Dr. Swore is going to talk about how
Mm.
their the success of their program was really dependent on finding the right person at the health department. And who your right person is going to vary depending on what county you're in. And so what I really want to emphasize today is you just have to find the right person. And if you are overwhelmed by that, you can call, your local health department medical director. You can call me and we can say, oh, that's an easy question. You need this person from the health department and this person from, Lansing Area AIDS Network, or this person from, Access in Dearborn, who provides Ryan White services in Dearborn. And so we can very easily do that. And please don't feel overwhelmed by that, because it is a hybrid, a very hybrid approach in very areas. And if you're in the Detroit area, folks have a lot of choice. And so who you start with in the Detroit area, because there are, 6 or 7 different locations. And so then you can almost give people a little bit information on options versus, for example, if you're in Alpena, you really kind of mostly have one option, so, but we can navigate you through that. And the local health department is a great place to start.
That's great. Actually, I was going to ask you kind of a follow-up was like, how do you get started?
Yeah.
If you're interested in, potentially implementing a program, whether it's in the emergency department or somewhere else. And it's great to sort of know about that. And then I think the other thing I'd say too is, and Sam, I don't know if you can like pop in your email. Um, so we also, in this partnership, want to support implementation of these programs in your own emergency departments for those that might be interested in that, here on the line. And so please reach out to us to, use that email from Sam, who's the project manager for this work, because we want to support this work and we have a lot of tools and resources to make it easier. Certainly open to other questions. We have time.
Clearly, I'm seeing now that I spelled my own email wrong. So let me fix that.
One thing that I feel like we talk about a lot in our conversations, and that when we have talked with health systems before, sometimes folks have had experiences with um, maybe lack of trust in the connection process. And I would like to take this opportunity to just be like honest as a group, um, and encourage some conversation about what are some hesitancies or maybe experiences or fears around this connection process in engaging with that. We've heard things about like long timelines between a positive result and a connection to care or a follow-up, or we've heard concerns about adherence to treatment and patients actually following through. So if anyone has any experiences with that, please, more than willing to and would love to hear some of these experiences, because I think that's helpful for all of us as we learn and go through this.
Yeah, I agree with that, Sam. Like, I'm always impressed also by the success stories that I hear. Again, so working in the emergency department, you kind of, naturally lose track of the follow-up with your patients. And I think we're gonna hear some good stories about that in our future learning series as well. But definitely, those kind of examples are great if there are any in the audience, or if Katie, you've got some. If not, that's okay.
Katie, I was not super familiar with the ability to start patients on antiretroviral treatment immediately. How do you continue those if you're using samples or grants from drug companies?
Just, oh, okay. I thought I was on mute. So you're saying like once you give the med packs that you have away to a given individual, how do you replenish them for the next person that comes along? Or how does a given person, once they're finished with the med packs, continue on treatment?
Kristen, I think you're on mute.
The second, how the health department ensures that they continue with treatment rather than
Yeah,
just starting a
right.
med
So
pack and
that
finishing
so
it.
that's that is the whole algorithm that we just talked about with the Mind App program. So we really hope when someone gets newly diagnosed with HIV and they get linked to us, we either help them access Medicaid, which will then cover those medications, so long as, they're on Medicaid and eligible for Medicaid. And if they have too much money or make too much money to be eligible for Medicaid, then we put them on ADAP. There's very few people that the 500% FPL is quite generous and really for most people that don't have private health insurance covers that's a very generous FPL. So those are the two things as you just get someone to one of those Ryan White agencies, they will help either get the person on Medicaid. ADAP also provides 30 days of medications while the Medicaid um, process is going because it takes a minute to get on Medicaid. So we will even give people access to medications until their Medicaid is processed. So it's the system is pretty functional. We lose a lot of people at each step of the way, right? So you could say to someone, hey, I'm going to give you a med pack. You have to go into this agency. You have to call them on Monday. They're going to help you get on Medicaid and then people don't, or life happens, right? And so I don't want to infer that it's a perfect system. It's not because people fall off for a variety of reasons at each step of the way. But it's very possible if you give someone a MyStart med pack that they can get access to, medications through a pharmacy within, 2 or 3 days. So that is all in place.
I'm just going to pause a little bit longer, see if there are any other questions that come up.
Keith, I stopped sharing my screen, but I can reshare if you want me to,
Yep.
or whatever.
I think
Go
we're
back to
probably
us.
okay. Yeah. Okay. Well, we're certainly available for follow-up questions and comments as well. Um, I'm going to just plug our next learning series here. So we talked about this already a bit. This is really a series that we're hosting over the next year or so, tackling different topics, around this problem of, improving screening and ending the HIV epidemic, particularly from the emergency department context. So next session is in December. We're going to hear from a great example at Hurley, talking about their own project and what they've learned. So Dr. Swore is going to be presenting there. So please attend, and we'll key you into that with the listserv email distribution that we've got you on. The other thing is just to remind you about the Qualtrics survey. Please complete that if you haven't already done so. It's short. And then you do get some CME credits for those that want that. This is a bit of a new process for us, to be honest. We're going to send you in follow-up an email that will have the steps to claim that credit. It's through the University of Michigan, so you will need to log in and set up an account if you don't already have that. And I think the only other point to really highlight there is it's got to be claimed within 7 days, like 1 week. So there is a deadline on that. So if you want it, please just do that quickly.
Hey Keith,
Yes.
before we move on, I'm gonna pop the for the CMEs, just so everybody's aware, I'm gonna
Mm.
pop the links in the chat and some directions. But before I do that, I wanted to highlight, it looks like we have a question
Oh
in the
yeah,
chat.
thank you. Yeah,
So
thanks,
since we
Sam.
have some time, I wanna make sure we
Yeah.
get to it.
Yeah, so Katie, this is probably for you. I don't know if you can see it, but it's what is the best way to refer them to return to care for those patients that fall
Yes.
out of care?
Great, Mary. Great question. I'm going to put two links into I assume most people live in sort of Michigan or the city of Detroit. I assume this isn't probably a person in the UP, but I'm going to put the two links on how you access those phone calls, and you can just refer that person into our program, and then they'll take the rest from there. So just give me a second, and I'll put both of those in the chat.
Perfect. Thanks, Katie. So you'll get additional email communication from us with the CME links. I'm imagining there's not going to be an issue sharing the slide deck as well. It looks like Sam just put in a link to claim the CME, but that will also be in the email as well. Any final comments, Katie, rest of the team?
No, none for me.
Awesome. Well, thanks, Katie. Awesome information. I saw a comment about how great learning there was here. Thanks to all of you being here as well. And please stay tuned in and join us next time.